So what I'm going to do is just go through a few slides. These are slides actually I presented at the IACH meeting in Paris fairly recently, so I don't want to labor them too much. Maybe just draw focus upon a few of them that may be a good point for discussion. I'm genuinely interested to hear in the kind of observations of the group, particularly those involved in trials and trial evaluation. Yes, so I'm a pathologist based in Oxford, and I work with a group of engineers in Oxford and biomedical engineers interested really in the application of image analysis and machine learning to biopsies, and particularly into bone marrow refined biopsies in the context of MPNs. Image analysis really has got a remarkable range of opportunities and possibilities in pathology. For the first time, we can move beyond the kind of text-based descriptive report of biopsies and begin to extract features in a systematic, quantitative way and move away from this subjective assessment of biopsy reporting to something more systematic and more quantitative. It takes around 10 to 15 years to train a pathologist, and still we have this problem of measuring performance and consistency in path reporting. So we decided to use these approaches rendered by AI to look at particular features in the bone marrow refined biopsy in MPNs, focusing initially on fibrosis and also megakaryocyte morphology. There are only two of the features in MPN diagnostics, so we're not suggesting this captures all the relevant features, but they are, I think, very, very informative and a good first step. I won't say too much about megakaryocytes, apart from a brief few comments, but maybe focus upon some recent results looking at fibrosis in the context of a clinical trial. Towards the end, I'll mention a little bit about our future work and some of the comments we've had from patient groups and also other clinicians who are beginning to work with us in terms of how to generate reports which are easily understood and convey more information than a text-based biopsy report. So very briefly outline, the very first work we did was looking at megakaryocyte morphology in MPN. We know these are important features diagnostically used by pathologists. And we built a machine learning model, an algorithm that could work on a scan slide, routinely prepared scan slide of a marrow. We trained the model to spot megakaryocytes, to extract them from the image, and then we could begin to describe in a systematic way the morphological features of megakaryocytes, but also their clustering, their topological distribution in the marrow. And this was our first attempt on the top right to begin to describe so-called disease space. So this is a data-driven approach towards trying to capture the spectrum of features you see both within a reactive marrow and within an MPN. And just briefly, on the right-hand side in the green cloud, we have the combined analysis of around 50 patients with a diagnosis of myelofibrosis. On the opposite side, on the left, we have in gray a similar number of samples from reactive marrows, so patients with no evidence of a myeloid disorder. And in between, in blue and yellow, we have PV and ET respectively. When you do this and you plot this disease space, you can then move away from asking simple questions about what's the diagnosis on a new case. I think, where do the features sit in the context of all these analyzed samples? And we have here two examples of two patients, one represented by two blue figures, a blue circle and a blue triangle, and one a green circle and a green triangle. So both these patients were diagnosed, well, in green, the patient had a diagnosis of polycythemia vera, and in blue, ET. And after 4 years on a subsequent trephine biopsy, we saw a significant shift in the morphological and topological features of the megakaryocytes. And that corresponded very nicely to the clinical and molecular progression to post-PV and post-TT myelofibrosis, respectively. So suddenly we've got a handle on maybe beginning to track morphological features in a way which doesn't require a text-based report. And sequential marrow samples can be contextualized into this broader cohort. So in principle, that's what we're looking to do. In addition to the megakaryocyte features, more recently we've looked at fibrosis and tried to adopt a similar approach and to begin to quantitate fibrosis. Fibrosis is really hard to accurately grade using the WHO grading scheme, which gives a descriptive approach towards grade. and it can be very hard to distinguish reliably between the EMF grades. And within particular grades, we know there's huge heterogeneity, and it can be a real challenge to get a graded fibrosis. So what we did in brief is we trained a model to break up the trifine biopsy into small squares or tiles, and trained a model to predict the severity of fibrosis using a large cohort of manually graded trifine samples. And we trained a model to rank order all these tiles from the most fibrotic to the least fibrotic, and it could begin to predict unseen or new tile fragments from new marrow samples. And these tiles are given a score between 0 and 1, and 1 corresponds to the most severe fibrosis we see, and 0 is no fibrosis. These tile scores can be converted to a color to give a kind of heat map, and you can see here one image of a trifine sample. This is a reticulin stained bone marrow image, superimposed upon which are the individual tiles that are color coded. So in blue, you have tiles which are non-fibrotic or nearly normal, and in red, you have the most severe fibrosis that you can see. What's striking is the heterogeneity, the significant variation in fibrosis. This happens to be a patient with polycythemia vera, which often is very heterogeneous. So what we can then do is look for various metrics, one of which is the simplest metric is this continuous indexing fibrosis score, or CIF score, which gives a single numerical score to summarize the whole slide. But you can also think about capturing heterogeneity, variation of the distribution of the tiles. And you can also begin to group together tile scores into so-called bins to capture not just the average score, but the distribution. I'll come to why that's important in a minute. But in summary, what we can do is that by using these kind of approaches, we can tease apart more reliably our MPN subtypes. Unsurprisingly, of course, in primary myelofibrosis and secondary MF, you get high CIF scores, of course you do. That's not really a surprise. What's very interesting, though, is that when you look at the differential diagnosis of ET and pre-PMF, both of which by definition do not have a grade of fibrosis above grade 1, what we see is that there are significant differences, and that the distribution of the tile scores is significantly different between ET and pre-PMF. So although the average score is similar, the distribution is different. And in further work, we're beginning to see that these foci fibrosis, these microfoci fibrosis, seem to be enriched in pre-PMF, and we think they're a clue to fibrotic progression and are very useful for distinguishing patients who are at risk of progressing to fibrosis. Anyway, on the right-hand side, the bottom right, we have again disease space, capturing fibrotic features. And these are two examples of two patients who were diagnosed with myelofibrosis and subsequently underwent transplantation. And using sequential marrow samples, we can really track the extent to which there's fibrosis improvement or regression. And these patients underwent two different outcomes. Patient on the left, patient A, following transplantation had 4 subsequent biopsies over 23 months. Although there was some improvement in fibrosis with a more PV-like fibrotic picture, eventually the patient relapsed and had severe fibrosis similar to her diagnosis. By contrast, on the right, following transplantation, after the 3rd trifine biopsy, we could see significant improvement in fibrosis. And in actual fact, at 12 months post-transplant, we had almost normalization of the bone marrow stroma architecture. And what's interesting is the improvement in patient B's fibrosis antedated the improvement in the counts and the reduction in the clinical symptoms. So it seemed to be quite an early change seen within the marrow architecture. So that's going to brief over what we've done. When we look at marrow samples now, even at low resolution with these heat maps, you can begin to see very clear patterns and associations within the MPN subgroups. And again, blue is non-fibrotic, the kind of orange, yellow, all the way to red is more severe fibrosis. And again, ET is non-fibrotic. You can see at low power, low resolution, these are non-fibrotic marrows. And on the right-hand side, we've got myelofibrosis. What I think is interesting is in polycythemia vera particularly, we see in some patients very significant heterogeneity and actually quite severe focal fibrosis, which raises the question, when are these patients becoming post-PVMF? And I think we're really bad at spotting that morphologically. And it's very easy to miss these early foci of fibrosis. My personal experience is that when I see these rendering, these heat maps of the marrows, I begin to report marrow samples differently. I begin to go after areas of interest that are flagged by this mapping approach. So having said a bit about the background, maybe I thought I'd spend the next few minutes talking about a recent experience we've had looking at a trial cohort. This was a phase 2 study of zinpentraxin alfa ZPN, or PRM151, in myelofibrosis. I'm not involved in the trial. I wasn't involved in the trial design or primary reporting. And we've only had access to the stage 2, phase 2 samples. So I can't speak too much about the individual clinical responses. We haven't had any exposure to them. We've simply had access to the samples. But for background, the stage 1 phase 2 report, which is recently published in Hematologica, showed that in patients receiving ZPN either as monotherapy or in combination with RUX, who had either intermediate 1, 2, or high-risk MF, there was around a 33% response rate at 24 weeks, and around a third had evidence of a 1-grade improvement by manual evaluation. We were shared samples from the stage 2 trial, and we didn't see all of the patient samples. We had 50 samples from 50 of the 97 patients, all of whom had had 3 bone marrow trophine samples taken during the trial, 1 at screening, 1 at cycle 4, and 1 at cycle 9. This work is soon to be published along with the clinical data. I'm just going to give a summary of the pathological analysis of the trophine samples across those three time points. So this is just a single view of all the samples on the trial. This is a myelofibrosis trial for patients who have been either heavily pretreated or have a long-standing diagnosis. And if you'd shown this to me at the beginning, I would not have guessed this was a collection of patients, all of whom had myelofibrosis. Many marrow samples here are really not very fibrotic, as compared to those in the bottom right, which have quite severe fibrosis. So very, very heterogeneous group of patients, even before doing any analysis, which was a bit of a surprise. When we look at our automated analysis and compare it to the manual review, so these patients were recruited to trial on the basis of the local pathology report, and then they were centrally reviewed by 3 expert pathologists, independently reviewed. On the left-hand side, we have a figure capturing the manual scores and how they corresponded to our automated SIF score. Now, I should emphasize the SIF score, which is the summary average score of the tiles, is not easily translatable to a WHO MF grade. So we can't say a particular SIF score equals a particular manual grade. The point here is that when we look at the scores and compare them to the manual review, a number of things emerge. Firstly, there is huge variation in the objective quantitative fibrosis within the individual grades given by pathologists. And also there's significant overlap between adjacent grades. So much so, in fact, that there were patient samples here that were graded as being MF3 by pathologists, but had fibrosis that was no more severe than many patients given grade 2 or even some given grade 1. When we overlay the screening bars, I should say, by the way, all this data here corresponds to the samples at screening, at entry into the trial. When we superimpose these figures onto our disease space of fibrosis, we have these dots corresponding to our disease space in myelofibrosis, as you'd expect. That seems very sensible. High average SIF scores and high degree of heterogeneity. That's not a surprise. What is a surprise is the number of patients who have patterns of fibrosis, which are really very rarely seen in bona fide myelofibrosis. And there were some patients even who had very little fibrosis that I think is hard to reconcile with a diagnosis of MF. And this was a surprise, given this is an MF trial. And when we then look at the samples taken across the trial, based upon manual review, there was around about a third of patients showed a single grade improvement at one of the time points, either at cycle 4 or cycle 9 on the trial. A similar number, we observed an improvement in the CIF score when comparing the screening sample to that of cycle 9. Although that number is similar, we're measuring something quite different. So these aren't necessarily the same patients. And in fact, there were many patients where there was significant discordance between the manual review and the CIF scores. And I should say also the kappa scores for the manual review were often quite poor for many of the patients who were regarded as having an overall 1-grade improvement. And there was a majority voting approach on the trial. So if 2 out of 3 pathologists agreed a single grade improvement, that was taken as being the definitive read. What's intriguing is that when one looks at the individual patients and compares each of the 3 samples, we can split them down into the change of fibrosis across the trial. And on the left-hand side of this figure, we've got all the patients who showed an overall reduction in the CIF score. And on the right-hand side, patients who showed an overall worsening in the CIF score. And we've just shown the pattern of the CIF score across the 3 biopsies. So there's 3 points for each patient. It's been color-coded just to make it simpler to read. So the patients whose biopsies are colored in blue had a relatively high CIF score at diagnosis at screening. Those in green, an intermediate, and those at red, a low CIF score. These are just arbitrary measures to give a feeling of the spread. What we observed is that the patients in whom we saw a significant improvement in the CIF score, guess what? They had severe fibrosis at diagnosis. Of course they did. How can you observe a grade 1 improvement in fibrosis if you haven't got severe fibrosis? There were patients on trial with very minimal fibrosis who actually showed evidence of fibrotic progression on trial. Hard to understand why they're progressing in this time course, but we don't know what the previous diagnostic history is. The conclusion, or a conclusion we draw from here, is that actually within this cohort, we would argue there is a subcohort of patients who are ever going to see any improvement in fibrosis, which makes you ask questions around utility of enrolling patients with this heterogeneity in fibrosis. And these are just some examples of where we plot these patients on our disease map. These are 2 examples of patients who responded very well across the trial. And on the right-hand side, we've got some low-power thumbnails of the biopsies. We have to be careful about samples which are technically insufficient and likely represent a sampling issue. But we can see in the top right-hand corner, compared to screening, this particular patient showed a significant improvement in their marrow fibrosis, near normalization of fibrosis, something we very, very rarely see on patients who are in our normal practice for MF. And a similar degree of improvement for the patient at the bottom, although again, the middle biopsy at cycle 4 is relatively small. And we can plot these on our CIF space and see this progression from right to left, from a typical pattern of fibrosis seen in NF towards either the normal or reactive disease space and or a feature of distribution more commonly seen in PD. We're not saying these patients, of course, have changed diagnosis. We're just saying that the pattern of fibrosis is different when compared to diagnosis. And of course, we can compare this to the manual score. So what can we conclude from this? Well, I think we have to be careful. Of course, we've not yet seen the clinical outcomes in this trial and linked them to the pathology. That's to come. Nonetheless, I think what's clear is that the quantitative analysis that we've performed identifies and captures features which are simply beyond manual assessment. The spectrum of heterogeneity within the trial was a surprise, and I think is a concern in terms of understanding trial recruitment. I think our approach, while still a research grade tool, I think has real application to help pathologists accurately understand the biopsies that they're asked to evaluate in trials. I think there are subcohorts of patients here who represent either a different disease group or a very different biological group. Using these kind of approaches, we can visualize these in a much more informative way and ask far more insightful questions about the performance of patients on trial and drug efficacy. I would argue that this kind of approach should begin to be integrated into trial design and thinking about power calculations for recruitment. we're not saying for a minute that this replaces the pathologist. I think this is a way of augmenting pathology reporting. And my experience anecdotally is that when you take three pathologists who disagree or there's discordance on a case, when you show them this kind of visualization as an objective measure of the features, it's a very good way of constructing a discussion and clarifying the disagreement or doubt upon biopsies, particularly when looking at focal abnormalities. Of note, the megakaryocyte features in here were quite unusual and very unlike those analyzed previously in Oxford. I think this reflects the fact that we haven't yet seen in our analysis in Oxford many patients that were heavily pretreated, certainly not those who've been pretreated with RUX. So we know we have to do more work in describing disease space, and clearly this warrants kind of further work more generally. And kind of finishing off, I would say that this ties into a broader effort within Oxford. We are trying to expand our cohort of patients that we analyze to get a better description of disease space, and beginning to think about how will these kind of tools be deployed in terms of routine reporting. So we're going to run in parallel manual reporting and visualization using these AI approaches and having joint reporting. And this will be part of a rolling prospective audit. And we'd be very keen, in fact, we are very keen to think about potential collaborations with other centres. And in the future, my view is that these kind of approaches, when they are validated, when we have confidence in their prediction, and we have a better feel from large multi-center cohorts, I think we should have a strategy for teasing apart individual features within the marrow in a quantitative way. And depending upon the features of relevance, either diagnostically, prognostically, or in the context of trials, we can think about identifying them, measuring them in an objective way, and improving our overall evaluation and description and definition of disease modification. So that's really a summary of what we've been doing and where we think we're going. And as I said before, I'm particularly interested to know whether you agree with me that this is the kind of thing that we should think about deploying in the context of trials. And we're just beginning to have these conversations with some trialists, but I think it's something which has potential, but really need to think about how to encourage people to have confidence in this approach and how best to deploy them. And last slide here, just showing the broad collaborations we have in Oxford between hematologists and pathologists and engineers. And again, we're really keen to look for collaborations both within Europe and also in the US. So really delighted to have any comments, any other discussions. Thank you very much. I'm just looking at the chat. Yes, I'm very happy to share these slides if anybody's interested. And in addition to MKTP, have you used machine learning synthesis? Yeah, so I think, by that do you mean in terms of the distribution between cell populations, clusters, and single cells?
Yeah, so one of the things that we looked at within the context of the Manifest-2 trial, and we teamed up with Mohammed Salama for this aspect, is the concept of declustering as a biomarker of therapeutic success. And so the distancing between the megakaryocytes, and at least in the analysis that we did, the preliminary analysis, it did look like if you had I think a greater than 15% increase in the distancing between these megakaryocytes, that correlated with spleen volume response. It was sort of the first time I ever saw this. People have looked for changes in the marrow, but no one's ever really correlated with the clinical outcome as such as SVR. So I thought that was interesting, but not completely teased out. We don't know what. I don't think anyone's ever looked at, and we intend to look at it. We don't know what is the mean distance of megakaryocytes in normal marrows, ET, PV, MF, prior to RUX, after RUX, in the setting of combination therapy. So it's hard to put it in context, but distancing of megakaryocytes, I think, would be interesting. The other aspect of the bone marrow that I think, and I'm not a pathologist, but I always think is very fascinating, and I don't think is fully understood, is looking at and measuring the fat content in the bone marrow and fat cells, and whether that provides us with some insight into the biology of the disease or the treatment response. I mean, all of these attempts unless we can correlate them to something that actually is clinically meaningful or just an exercise in machine learning. So to me, the benefit of what you're doing ultimately is going to be, can we have early, is there a way to use machine learning to predict in an early form, what to expect with the therapy or an outcome with the therapy?
Yeah, thank you for those comments. I agree with all of that. With the addition that I think another immediate application is just understanding your patients at screening as well. I think just having a really good sense check upon what you're recruiting to trial. Addressing the megakaryocytes is a really interesting observation, because Tiziano and I have been talking about a cohort of his, albeit a small number of patients. And what we have a glimpse of is that actually changes in the topological distribution seem to be quite closely related to evidence of clinical response. We initially thought that it was going to be phenotypic variation. Actually, the strongest predictor of movement across disease space is topology.
Yes.
The change in clustering seems to be at least one of the more important features of normalization in the marrow, whatever that means. So I think there's probably something in that. Anecdotally, what surprised us is there's something very particular about CALR mutant MPNs and topology, and that we have some very, very preliminary data showing that CALR expression is predictive with an individual case of the propensity of a cell to form a cluster. So I actually think changing topology is really, really important. And I suspect it's also related to the background stroma. So we're beginning to look at not just changes in the clustering, but also whether the marrow is normalizing as well in terms of stroma. So I think you're absolutely right. And the second point also, I completely agree with you. We have to avoid simply finding data, an AI approach on retrospective data and looking for associations. That's not good enough. We have to be able to come and say, here we have on a prospective data set features which are consistently predicting clinical response and progression. I think you're absolutely right. I think we have to be realistic and say that we're still at a phase where our algorithms are trained upon relatively modest data sets. Why is that? Well, it's because it's very hard to get hold of good data sets that have been properly curated. We need multi-center collaborative studies. As more and more groups begin to develop these approaches, I think we should have a forum for doing toe-to-toe comparisons of algorithm performance. And we need to move towards prospectively collecting samples and analyzing them. And in the UK, we have funding to build something called Hydra, which is a research database. What we want to try and do is get all new MPN diagnostic marrows shared as part of this cohort, to both validate and improve our algorithms, but build this prospective data set. But no, I absolutely agree with all of your comments. And I think we have to avoid, I'm very keen that we avoid this simply being another footnote in pathological descriptions of marrow features. That's just not good enough. Fat, sorry, I'm a bit ignorant about fat. We tend to ignore fat. It's dissolved up, of course, in marrow processing. There's more and more evidence that fat distribution, fat metabolism informs a variety of blood cancers. I think you're probably right. I think changes in fat distribution, fat metabolism, and biomarkers of catabolic activity in the marrow are going to be increasingly relevant for AML, MPN, and MDS. We've done nothing on that yet, but so I think it's a really good point.